Hi everyone, my name is Omar Khatib and I'm here at ASN 2018 Kidney Week and I'm here with Dr. Hung. Dr. Hung, thank you for joining us.
Sure.
And before we get things started, Dr. Hung, tell us a little bit about yourself.
Sure. My name is Michael Hung, and I'm a clinical nephrologist with a particular interest in critical care nephrology. I work at the University of Michigan in Ann Arbor, Michigan, and one of my roles there is I'm the Associate Chief for Clinical Affairs for our division.
Fantastic. And I understand that you just co-chaired the Critical Care Update this week, correct?
Yep. It's a great pleasure to serve as a co-course coordinator for the critical care nephrology pre-course that we have here at ASN, and it's a great opportunity to chat up some of the real leaders in the field of acute care nephrology and critical care nephrology, and get updates on what's going on in the field, and to get people up to speed on best practices.
Very nice. So let me ask you, when you were in medical school, what got you interested in nephrology? I take it you first got an interest in internal medicine and went into nephrology, but what's the story there?
Yeah, it's like you said, in medical school I learned about internal medicine, and I just really enjoyed the patient care aspects. I really enjoyed the longitudinal aspect of managing chronic diseases and working with patients and families over time. So I did an internal medicine residency. I wasn't necessarily interested in nephrology coming out of medical school, but then in residency, I really got to know some of our nephrologists at the University of Cincinnati where I trained, and they were just fantastic teachers, fantastic role models, and eventually became fantastic mentors to me. So it's really following in their footsteps, seeing how they manage patients with complex kidney diseases is really them that I think inspired me to follow in their footsteps into nephrology.
Was there any point in time or anything specific that you remember that kind of inspired you in the direction of nephrology when you were training or when you were in your third and fourth year?
In medical school, actually, I guess there was, now that you mention it, there was an attending of mine on one of my very first general medicine rotations, Dr. Jim Kaufman, who I still remember and have had a chance to catch up and talk with. He was my attending. He's a nephrologist in Boston, and I was presenting a case to him, and just his ability to pull out what I thought were not necessarily relevant details from the case and synthesize it together and take pieces of a puzzle and make a full picture of it just blew my mind. I mean, the ability for him as a diagnostician to come up with what was most likely going on with our patient. And of course, he was right. And it just completely blew my mind. And again, at that time, I didn't necessarily think I was going to be a nephrologist right away, but when I think back, he was probably my first nephrology role model. It really showed me the thought process, the breadth of knowledge that nephrologists need to have in understanding all the different systems of the body, and to come up with the right diagnosis for our patients.
What was the most memorable thing that he ever told you?
I don't know about specific things. I'm not sure I can remember specific things that he might have told me, but it was just moments like that on rounds where those classic light bulb moments, I had them watching him. And seeing how he was able to put things together, and that's what I knew I wanted to be like. So that was really that example.
And now, so this week with Kidney Week, it seems like there's a lot of excitement, and it's a very active group on Twitter and everything. From the critical care update, anything specific that sort of worth mentioning for the younger nephrologists that weren't able to make the meeting?
Yeah,
we don't want to give them all the cliff notes, but
no, it's that's a really challenging question because we had I think it was over 30 talks from different speakers covering a variety of topics. Some more critical care focus, what the nephrologist needs to know when rounding in the ICU, but from an intensivist perspective, and then several more that were more nephrology specific, like the tips for how to best run your continuous renal replacement therapy program, for example. So there were a lot of great things. One talk that I enjoy every year was given by Kathleen Liu, who is both an intensivist and a nephrologist. She's from UCSF, and she gave us an updates in critical care nephrology over the past year. So really looking at some of the latest literature. So it's always nice to get a real expert's opinion as to how to interpret the literature, and we got to talk about things such as the latest sepsis guidelines and things like that. We had very well-known people, renowned experts like John Kellum and Ravi Mehta come and give us talks on, Ravi gave an amazing talk on fluids as drugs, and there's been a lot of literature on that in the past couple of years, and so it was really great to hear his perspectives on what were some of the key points, some of the best practices that we should be adopting. And one particular area that I'm interested in is the problems that develop with fluid overload. And after resuscitating, we know we should resuscitate people, but how quickly do we switch from that resuscitation phase into a de-resuscitation or de-escalation phase? That's still more to be determined in that area. But I think the recognition that we can't just keep giving these patients fluid, so we have to think about when we de-escalate, start to even pull fluid off to help our patients really recover. So. And you mentioned Twitter, so people can check out the hashtag CritCareNeph and see a lot of the highlights, including pictures of slides and things like that, which our speakers are great with sharing. So
very nice. And CritCareNeph, that's CritCareneph. Yep. Okay. Yep. Fantastic. Now, one thing that's been interesting, so we're visiting here from Silicon Valley, is a lot of the new and interesting technologies that are coming out now, but more importantly, what kind of lies ahead for physicians, down the line in the future in terms of augmenting skills and really giving access to things that you didn't traditionally have access to in medicine. But if you kind of put the futurist hat on right now, what does the future of nephrology kind of look like for you? Let's say 5-10 years from now, if you had a magic wand and you can see or have access to anything.
Sure. I think there's a few things that I would think about. One is, and actually several of these things did come out for discussion at the Critical Care Nephrology pre-course. So one is the concept of alert systems and associated clinical decision support systems for acute kidney injury. Okay, at this point, I think that we all feel like we do a pretty good job recognizing acute kidney injury, identifying it, but the reality is a lot of times we're fairly late in the game, and so a lot of people are working on different predictive analytics type work especially with using the electronic medical record to try to predict which patients are at highest risk for acute kidney injury, and in particular which patients may be already developing acute kidney injury. We do know that alerts alone are not going to be enough. Just telling people, there's concept of alert fatigue, unfortunately. Physicians get overloaded with the alerts that come up from the electronic medical record. But it seems to be, at least in some studies, that when those alerts are associated with some specific recommendations, what we call a clinical decision support, that does seem to result in a change in behavior, which can in turn result in potentially decreasing the risk for acute kidney injury. And over the past couple of years, there have been a couple studies that have really suggested that's possible. So that I think is pretty exciting. I think in the future would be I expect that we'll see more and more of these kind of alerts with a clinical decision support modules. Probably not just in acute kidney injury, but I think acute kidney injury is a key area for that. So. Another area I think is we had a speaker come and talk about the use of point-of-care ultrasound, and so that is not a new technology per se, but using its application in the ICU and for nephrologists is a relatively new pursuit. And I believe here at ASN they have a brief course for that, and certainly at some of the other meetings around, nephrologists are starting to get training in point-of-care ultrasound use. And it could be an interesting way to guide fluid removal, and fluid administration in the future. I think there's a little bit more work that needs to go into that, but it's certainly coming our way, and the speaker, Nathaniel Reisinger, in our course even made the analogy that it's the modern stethoscope, is these portable handheld point-of-care ultrasounds. So I could see technologies like that coming along, enhancing our ability to assess patients. And then a third area that I'm particularly excited in is Basically, trying to better identify different subtypes of patients with acute kidney injury to guide our therapy of them. So the concept of precision medicine, basically.
Is that, and when you say subtypes, are you referring to like what would be the rifle score, or is that, or is?
No, not.
I'm still a novice.
Yeah,
and I'm learning more.
So the rifle score would give us staging, so severity of acute kidney injury. But when you think about it, acute kidney injury is a syndrome. Right? All it describes is a decline in somebody's kidney function that happens pretty quickly, just like the name sounds. But the different causes for it are innumerable, really. Okay, and so why do we call the whole umbrella acute kidney injury and try to treat all acute kidney injury? We should be thinking more about, okay, this is the acute kidney injury subtype associated with this, or maybe because of this genetic predisposition, maybe, or this enzyme defect, or et cetera, et cetera. That's a future that I think could be very exciting. We've, of course, seen this in the field of oncology. Right? Lung cancer is not lung cancer anymore. Breast cancer, certainly not breast cancer. We're talking about what types of receptors, what kind of genetic mutations there may be, and that's guiding what type of therapy is offered. And because we know that the different types of, say, breast cancer will respond differently to different treatments. Okay, we don't have that yet in nephrology in general, and certainly not in acute kidney injury. But I'm very excited. There's a lot of work going on in that, and I'm very hopeful that in the future we will have some more of that, what we're calling precision medicine, where we can not just take a patient and say, oh, this patient has acute kidney injury, and we're focusing on this heterogeneous syndrome of acute kidney injury, but applying it to one person. Hopefully there will be a day, and not in the not too far future, where we can look at this patient. It's like, okay, their syndrome is acute kidney injury, but these are their characteristics. This is a particularly pro-inflammatory subtype, or this is they have this genetic predisposition, or something else like that, where we can then use that information to provide more targeted therapy that will be beneficial to them, and not use therapy that won't be beneficial to them that might have side effects. So.
And so, as a nephrologist, between, having predictive health technologies where you can see an event like an AKI occurring in the future, and then of course with those patients who come in and have AKI, precision medicine to have a lot more targeted therapies, between those two things, which one do you see coming faster for nephrologists is more of a reality? Because a lot of these things take a few years not only to develop, but also for adoption and behavior modification.
Yeah,
but between those two things, do you feel like they go hand in hand, or one will precede the other?
I think they will go hand in hand to some degree. I mean, you have to be able to identify ways to even define different subtypes, and then you need to look at those subtypes and do clinical trials to show that it does matter, having the different subtypes. So I think it's an iterative thing. The clinical trials will inform further subtypes. Using those subtypes will inform the design of future clinical trials that are needed ultimately to show that something makes a difference in patients. But in acute kidney injury, we have a ton of, unfortunately, negative clinical trials, meaning that they did not show significant benefit in mortality, which is, of course, one of the big things that we're working on. And one of the thoughts is that, well, maybe we didn't show benefit because we're treating everybody the same way, but they're not all the same. And maybe there are patients that will respond to this therapy, and there are some that won't. And if we can pick the ones that will, that's where we're going to get the biggest bang for our buck, and again, limit the risk of from exposure to something a patient's not going to respond to.
Got it. A couple more questions. We want to be mindful of your time. We appreciate you taking time with us, but for you mentioned earlier with a physician who mentored you that a lot of times it felt like he took a few random pieces of the puzzle to complete a full picture, and I think that it seems that a lot of medicine has to do with that. The older version, which is you watch your attendings and senior physicians almost like magicians, right? Do these things, but as technology comes out, it sort of evens the playing field and standardizes these things. But there's still a lot of young nephrologists out there trying to learn how to improve their intuition when it comes to this. I think technology and intuition needs to go hand in hand. So, kind of a big question here, but any advice to younger nephrologists who are trying to improve their skills, and and essentially become more like clinical magicians while the technology
Yeah.
catches up.
Yeah. I mean, medicine is still very much an apprenticeship, and there's a reason we call it practicing medicine. I certainly don't think I have all the answers. One of my joys is coming to work every day and knowing that I'm going to learn something new every day, and I've certainly been humbled many times. So, the advice I give my fellows is the day you think you know it all, that's definitely the day you should hang up your stethoscope and call it quits. You should be humble. We should recognize that medicine is humbling, and patients don't follow textbooks. Patients are complicated systems. But ultimately, I think it's getting as much exposure, practicing, being exposed to different things, reading on what you're seeing, reading up on what you're seeing, doing some research that way, and having an open mind to things. I do think there are things that can help with that in the future, just because there's so much information out there. So having some new technologies to help streamline the way information is processed or even interpreted could be helpful. But at the end of the day, again, because patients don't follow every rule, right? That's just not, I always say medicine is not engineering. It's just not as precise right now. If you look at the fact that any lab value, there's not one normal level. It's always a range, right? So that alone tells you that there's a lot of fluidity and variability. And so I don't see, that's why I don't see computers, even AI, taking over a physician's intuition, but also that intuition, it just has to be developed over time, seeing many patients, practicing, learning, speaking to others. And that's one reason that I really enjoy being in academics, is because I'm a better doc when I go to the bedside and I have to explain my thought process, not just to the patient, of course, but also to my learners, to my fellows and the students on rounds. And I have to be able to demonstrate that, yeah, there was a thought process in this. I did think through these things, and this is how we got to that point. So it keeps me on my game. And again, I get to learn something new every day. So.
Nice. I guess it goes with that adage, he or she who teaches learns, right?
Yep.
So it sounds like, I guess your big takeaway to younger nephrologists is that to always stay curious and intellectually
Absolutely.
driven. That sounds like it's the key. Yeah, and it's interesting you mentioned the idea about AI and computers not replacing doctors, and we absolutely agree. I think there's a big misnomer out there that that's what was driving Silicon Valley, but, the AI has to learn from something, right, or someone, and usually that's the human being. And so it sounds like, the way that medicine's moving forward is not necessarily replacement, but more of an augmenting of skills so that physicians can kind of go back to the patient's bedside instead of spending more time with technology. Does that sound correct?
Yeah, no, I think that would be great. Ultimately, medicine is very much a human interaction specialty. That's, at the end of the day, that's my favorite thing. I love my toys, I love my technology, my labs and all that stuff, but ultimately I like being able to sit down one-on-one with a patient or with their family and to explain what's going on. There's nothing intuitive about kidney disease, and especially with what I do in critical care nephrology, these patients are often very sick, and I'm glad that I'm able to sit down, take some time and explain it to them, and hopefully make sense of it for them and guide them through that journey. So.
Couple of quick rapid fire questions and we're going to wrap up. And again, thanks for spending some time with us. But you mentioned hashtag CritCareNeph on Twitter. But aside from that, the beauty of the internet is that you can get so much information. Any other additional resources, Twitter handles,
Sure.
LinkedIn? What do you follow? Where do you go for information?
Yeah, well, certainly related to kidney disease, one of the exciting things has been NephJC, which is NEPHJC. The JC is for Journal Club, and so they do an online journal club a couple times a month, and they pick an article, they'll spread it out, and actually they even make it easier. They will do a summary, a visual abstract, and there will be a blog giving some opinions, a quick summary of it, and then there will be a Twitter discussion using that hashtag where people can comment, and there's a moderator who will ask questions based on the article, and oftentimes they're able to get the authors of the article to come in as well. So it's a great way to keep up on the literature, to get opinions from the authors potentially, and certainly experts in the field and seasoned clinicians. And it's a great way to feel part of the community and learn. So, I'm representing here.
Oh,
myself.
you're repping it.
My,
Look at that.
JC pin and
very nice.
Here, so,
very nice. And that's at NEFJC on Twitter.
Yep.
Wonderful.
Yeah, so a couple times a month, and they have a one on European time as well as one North America time. So
does it get a little competitive, or is it mainly an open public forum?
No, it's amazingly collaborative and friendly. Yeah, it's fantastic.
Nephrologists are very friendly people. I noticed.
Absolutely.
This has been a very friendly and nice meeting. Everyone's happy. Everyone's getting along well.
Yeah.
So, and then what about offline? If you had to recommend, a few books, is there any books that you are not necessarily on nephrology, but in terms of you're a teacher and a leader in your field, so any books like that are really good for self-development and leadership? Anything that comes to mind?
For self-development and leadership, there's a variety of books out there. I always think the Malcolm Gladwell books are very interesting, just in terms of understanding different thought processes. You mentioned leadership, and one thing that I actually teach in a course at the University of Michigan Medical School called Leadership. And
is that open for all residents and med students, or
it's a medical student required course, actually?
Oh,
yeah.
So wow,
it's pretty exciting. We developed this leadership curriculum starting a few years ago. This is our 4th year, I believe. And we're one of the few and first medical schools in the country to develop leadership really into the curriculum. And it's part of every business school, but I think it definitely has a role in medicine. So one of the things that I feel like I have really benefited from in terms of leadership training is doing some of these online strength finders kind of thing. One thing that comes to mind is like the Gallup Strength Finder, and really kind of understanding a little bit more about myself and what my strengths are. Understanding what your strengths are necessarily means you understand what your non-strengths or weaknesses are. And honestly, that's helped me quite a bit in my professional interactions, working with teams and things like that, just to know a little bit more about myself. So I wouldn't have necessarily guessed that before I did it, but I have found that to be really helpful. So for people that have an opportunity to participate in those kinds of things, learn a little bit more about them. There's many different ones other than the Gallup Strength Finder, but it just gives you a perspective on your leadership style, your learning style, your teaching style potentially, and your team interaction style, and those of others, and how they can be hopefully complementary as opposed to antagonistic. So
absolutely.
No.
And it sounds like the big theme here and takeaway, I think, for a lot of us is that to be open-minded and, more importantly, curious, not only about yourself but the environment and things that you're interacting with. Yep. Well, fantastic. Well, Doctor, how can everyone find you online? Do you have a Twitter handle?
Yeah, my Twitter handle is @KeepingItReno.
That's very punny.
Yeah,
that's nice.
So that's what I use it for. It's all about building up nephrology.
Well, fantastic. Well, we really appreciate you taking time, and we're happy that nephrologists like you exist and can spend time inspiring us all. So, thank you very much.
Thanks.